All right, it's 1:30 now, so we'll get started. So welcome everyone to our virtual education program. My name is Shelby and I am the education coordinator at the Alzheimer's Society of Nova Scotia. We're very excited to be able to connect with you and learn today. We're using Zoom for Healthcare, which is an online technology that helps us connect with you securely. If you're experiencing any troubles at any point during this presentation, please send a message in the chat box to the ASNS host, and they'll try to help you through that. For today's session, all participants have been muted with their videos turned off. And with these privacy measures in place, we will be able to record the session for future use. As we begin today, I would like to acknowledge that we are learning in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq Nation. We are all treaty people. The Alzheimer's Society of Nova Scotia is committed to undertaking work to create collaborative and respectful relationships. Together, our goal is to identify and develop tools that align with the beliefs and needs of Indigenous, African Nova Scotian, Acadian, and all equity-seeking communities across our province. We are committed to walk as community members in the elimination of racism and discrimination from healthcare and across society. At the Alzheimer's Society of Nova Scotia, we're working towards becoming a more diverse and inclusive organization where all individuals and Nova Scotians feel a sense of belonging. We use the acronym IDEA, which stands for Inclusion, Diversity, Equity, and Accessibility, to apply a person-centered lens to our work and ensure we are fostering a sense of belonging for all that we do. So thank you for joining us this afternoon. The audience today includes people living with dementia, people caring for someone with dementia, and people who just want to learn some more. So kind of the run of show today, we'll have about 30 to 35-minute presentation, followed by 15 minutes of Q&A. So please feel free during the presentation if you want to ask questions in the confidential chat box that is addressed to the ASNS host. And just remember to press send, and we will look at those questions and get to them at the end of the presentation. Today's presentation will explain the Geriatric Medicine Outpatient Clinic and the services they provide. The team will be discussing receiving a diagnosis of dementia and the support services that they offer. They are a multidisciplinary team who assesses the overall frailty and memory of the senior population. So it is my pleasure to introduce Dr. Maia Von Maltzhan, who is a geriatrician with the Division of Geriatric Medicine at Dalhousie University. She serves at the Physician Service Lead of Geriatric Medicine Outpatient Services. She is also passionate about medical education and is the program director for the Geriatric Medicine Resident Training Program at Dalhousie. Her goal as an educator is to inspire trainees in discovering the joy and privilege for caring for older adults. Also with us today, we have Janet Wright. Janet graduated from Bathurst School of Nursing in 1992. She worked as a registered nurse in her hometown of Campbellton, New Brunswick. And believe it or not, at that time, there were no nursing jobs available. She went on to pursue her nursing degree from Dalhousie University, graduating in 1998. She is a nationally certified geriatric nurse in Canada, and she has been working 32 years in nursing. She has always focused her career in caring for seniors. She has experience in working in acute care, rehabilitation, travel nursing, and has worked in a remote fishing village nursing home. She has been with Nova Scotia Healthcare for 22 years, and currently she is the interim charge nurse for the Geriatric Medicine Outpatient Clinic. She likes to travel, read, and spend time with her husband and fur baby kitty, Oliver. And last, but certainly not least, today we have with us Kate Newton. Kate has been working with the QE2 Department of Geriatrics since 2013, including 6 years working as a staff nurse on the Geriatric Assessment Unit For the past 6 years, she has been working both as a clinic nurse at the VMB Geriatric Clinic and as a geriatric outreach nurse on the outreach team. Kate's nursing experience also includes time working on the surgical units at the QE2. Kate lives in Halifax with her husband and their 3 boys. And with that, the floor is yours.
Thank you. That's a very warm and generous opening. Thank you so much, Shelby. We can go to the next slide. Oops. So good afternoon, and thank you again for the opportunity to speak to everyone today. I'm Dr. Maia von Maltzhan, and as mentioned, I'm a geriatrician, and part of my role is serving as the co-lead for our Geriatric Medicine Outpatient Services. And here you'll see a little picture of what you'd encounter when you come to our clinic. Next slide. So we are a diverse team of people with a broad variety of backgrounds, including administration clerks, physicians, and physician learners. We work with nurses from both nurse practitioners and registered nurses. We have physiotherapists and occupational therapists who we work with, and they have a number of assistants who they also collaborate with in their care. There are social workers on our team, and we also often collaborate with neuropsychologists and psychologists. I'll just add as well that I have had the privilege of working in a number of different provinces or rotating there on electives, and I think we have one of the most robust outpatient teams that I've encountered. Next slide. So we largely see older adults with health issues related to frailty and dementia. Referrals come to us typically through primary care healthcare providers, although sometimes we'll also receive referrals from the emergency department or other specialists. We're located on the first floor of the Veterans Memorial Building, and in some cases, assessments might even be provided in a patient's home, particularly if the assessment is being done by one of our allied health colleagues, for example, from occupational therapy or physiotherapy, or there might be a high degree of frailty or mobility difficulties, in which case the assessment might be better suited to home. Next slide. Yeah. So many of our referrals are regarding the question of dementia. And dementia is simply a word used to describe health conditions that cause a progressive decline in a person's cognition or thinking. And that decline impacts their ability to do their usual day-to-day activities. We diagnose dementia based on information from a number of capacities. One of the big areas of information that we seek to understand is the history of changes. So the symptoms a person is experiencing, how those symptoms have evolved and over what time frame. And of course, how those changes are impacting their daily function. We also incorporate information from the cognitive testing, and sometimes the physical exam can provide helpful information too. We also look at additional investigations, usually blood work, and sometimes pictures of the brain, either through CT scans or MRI. And sometimes we'll also arrange for more in-depth testing of a person's thinking with our colleagues from neuropsychology. It's important to know that there are many different types of dementia, but certainly Alzheimer's dementia is the most common form of dementia. And part of the natural history of any dementia process is to know that people often benefit from more support as their condition progresses. So we anticipate that they will need more support with their daily activity as the condition evolves.
So I'm going to speak a little bit about the patient experience. So when the patient does come to clinic after you're given an appointment, usually the visit will last about 1 to 2 hours. And during that timeline, you will see a registered nurse and the geriatrician or a nurse practitioner. You may also see, we have residents and we have nursing students because we are a teaching hospital, so there may be other people involved in your appointment. You will be interviewed by the registered nurse, and typically the registered nurse will do the memory testing, will do a good review of medications that you're on, and will also do vital signs, blood pressure, and check your weight. And then the geriatrician will sort of do a complete physical exam. We usually will ask patients also, it's very important as part of our assessment, to bring a support person with them to the appointment, because they are asked to share their experience and their perspective as to what they're seeing. And that helps us sort of compile all the information together. At the end of the appointment, we usually explain to you and the caregiver or support person with you what the issues are and give a diagnosis of dementia if that's the outcome of the assessment. And then we offer recommendations about treatment, helpful community resources, or involve other team members if we feel that that's needed. We might refer also, and this is, each geriatrician is different, but we may refer you for blood work or other tests and specialists as part of the plan of care. And then we will also inform you if we need to do follow-up and see you again. Next slide. So there's several assessment tools that we use here in the clinic so that we can test cognitive function. The mini mental state exam is a standardized tool. We call it, it's known by the MMSE. And so that test sort of looks at different areas of cognition. For example, we're looking at memory, we're looking at language, and we're also looking at visual spatial, and whether a person is orientated to place and time. The Lawton-Brody functional scale is typically a standardized tool also, and it is completed by the family or support person who's with the patient. And that sort of gives us an idea of the level of day-to-day function that the person being assessed can do. We look at things like grocery shopping, driving, medication. That's just a few of the activities we look at. One of the other tests that we use in clinic is the Montreal Cognitive Assessment Tool, otherwise known as the MOCA. It's a standardized test, and most often we will use this test on patients who are having just mild cognitive issues or people who have a higher level of education and they score very well on the mini mental state exam. The other tool also that we may use is the frontal assessment battery. And this again is a screening tool of executive function. So looking more of the planning, can the patient follow instruction, abstract thinking, again, vocabulary, and impulse control. And the other tool that we often will use is called the BCRS. So this is called Brief Cognitive Rating Scale. And this assessment tool helps us sort of stage the level of dementia where the person is at. So a person could be either in the mild or moderate or severe stage. And we ask them basic questions that, they likely should know, like who their children are, who their grandchildren are, and other items that we would ask them. Next slide. So some of the frequently asked questions that we do get here in clinic are how quickly are patients seen in clinic? So we do have a method of triaging referrals as they come in, and we do have categories that we place each referral in. There is an urgent category. We usually aim to see those people typically in 14 days. And those are the people who are more at risk and we feel that need to be seen right away. The semi-urgent category, usually we aim to see these people in 3 months. So we are concerned about them, but we feel that they can wait a little bit. And then if anything does change with them, well, then we can certainly see them urgently. And then for a routine, just basic memory assessment, It's usually right now, our aim is to see them within 6 months. And right now the clinic time our wait time is probably 8 to 9 months. Another question we get is, are there any drug trials available here in the clinic? Right now, currently, there are no drug trials going on. The next question also that we get is, can I be seen without a referral? Unfortunately, to access our clinic, a referral has to either come from a physician or a nurse practitioner, and it is required for the assessment. And then the last question sometimes we get is, will I have ongoing follow-up? So not all patients are followed. Most of them are not. Typically, that's the decision of the geriatrician. We may have referred you on to other health professionals for further assessment, or sometimes we refer you to the outreach nurse. Excellent.
Thank you, Janet. So Janet mentioned the outreach nurse, and I am an outreach nurse on our outreach team. So one of the facets of the Geriatric Medicine Outpatient Services is this robust geriatric outreach team. It consists of nurse practitioners, registered nurses, occupational therapists, physiotherapists, social workers, and we actually have 2 pharmacists that work with us as well. So we receive referrals from the geriatricians or nurse practitioners in the clinic. So if you've had an initial appointment with the geriatrician in the clinic, say, they might refer you on to one of the allied health professionals on the outreach team, or perhaps several of the members of the team. So that's who we are. What we do is we work individually or collaboratively, together to go out into the community, into people's homes to carry out geriatric assessments. That might look differently depending on what health professional is seeing the patient, okay? Because we all have different scopes of practice, of course, and different expertise. But generally speaking, we do share some common principles, and I just outlined some of those below. So we are a patient and family-centered service. And I think this is really important because we're very holistic, and we look at not just an individual's physical health and their cognitive health, but also their social situation, the circumstances of which they're living. And a big part of what we do is gather the perspective of the family or the caregivers. That's a really important piece of all our assessments. So that's the family-centered piece. We all share a home first philosophy. And that just means when we're going out to do our assessments, we're really looking at how to keep our patients at home if that is their wish. So that's how we operate. When we're doing these assessments, we're looking at putting in interventions or making suggestions that will help the patient to stay at home as long as they desire to. We have a risk management approach. So we identify risks related to frailty and or dementia, and we provide ways to help mitigate those risks. So some of those risks might be someone's living home alone and they're having trouble maybe taking their medications, for example. And maybe we're looking at ways to help lessen the risk of them having an adverse event because of difficulty taking their medications. Or perhaps somebody's experiencing falls and mobility issues, and we're going to offer some suggestions on how to lessen the risk of having falls in their home. So those are some examples of risks we might identify and ways we might strategize around that with our care planning. We have a least restrictive approach, and this is really just about balancing the risks that are present with the patient's autonomy. So that's really a person's ability, say, to act on their own values and interests, right? So needless to say, there's always a little bit of risk when people are living with dementia in the community, especially if they're living alone. But we don't want to be too heavy-handed. We want to work with them and make them a really important part of the decision-making process about what they want to do. And so that's a fine balance there. We can go to the next slide. So as a geriatric outreach RN, like I said, we provide assessments in people's homes. About 90% of the patients I see are in their own homes. Sometimes they do come into clinic if that's what they would desire, but usually the people we're seeing at home it's because they're having difficulty getting into clinic. That might be because of mobility issues, like their physical health. It might be because they have trouble with transportation and getting into the clinic, know when to drive them, or perhaps there's mood or memory concerns that are present that just don't make it impossible for them to get in and get out of their house. So we collaborate with within our team, but also with community care partners. So Continuing Care Nova Scotia, we often talk to care coordinators after we've done our assessments. That might look like advocating for an increase in care hours, or maybe introducing new services. Or sometimes with the patients that we're seeing, they haven't started any formal care. So it might be an actual initial referral to continuing care. We also collaborate with the Alzheimer's Society by sending in first link referrals so that caregivers and patients can get more information and get some education on the resources they provide. And then, of course, like I said, we collaborate within our team. So if we're going out to do an assessment and we find that there might be benefit for somebody else on the outreach team to see the patient, then we'll send a referral to that team member. So perhaps we're doing an assessment and we find that the patient would benefit from a more in-depth balance and mobility and strength assessment. We might refer to the physiotherapist or perhaps the occupational therapist for a detailed home function assessment. And then lastly, a large part of what the geriatric outreach RN does is education and counseling. So you can imagine when somebody's coming into clinic, we do have a 1 to 2 hour appointment, but there's not a lot of time to really to get that education sometimes in there, especially with initial diagnosis. So a big part of what we do is education with caregivers, and it can be around a number of things. We counsel on BPSD, which stands for Behavioral and Psychological Symptoms of Dementia. That's a bit of a mouthful. So this would be in line with responsive behaviors, or just if there's concerns with particular behaviors and trying to care plan around those and helping caregivers with that. We educate on dementia in general, what it is, how to stage it. We talk a lot about the current care plan, if it's meeting the patient's needs, and also what to expect in the future and perhaps planning for the future. Symptom management, we often work with the geriatrician that's referred to us. If there's symptoms that are arising, maybe disturbed sleep, it might be falls, hallucinations. There's a number of things there that we can help with. And helping caregivers with dementia-friendly communication strategies and teaching around that is a big part of what we do as well. And you can go to the next slide. So what to expect during an RN visit would be repeat memory testing, a vital sign check. So we always do a lying, standing blood pressure. We review medications, make sure they're on the right medications for them and taking them appropriately. A functional assessment, and that might be gathering information from the caregiver or family on how the patient's doing with their day-to-day function, but it also might mean a more hands-on assessment where we take a patient maybe into the kitchen and they show us how they reheat their food, or perhaps they show us how they do their laundry or that sort of thing. Education and counseling is provided, as I mentioned before. And then sometimes there are recommendations about changes to medications or perhaps introduction of certain medications. And that would be based on a review with the collaborating geriatrician after the visit. And in that case, we would follow up with the family about that. So that's some of what we do some of what I do as an outreach RN. And I think just to reiterate too, that the outreach team receives the referrals from the geriatrician or the nurse practitioner from the clinic, and that we're unfortunately not a service that can be referred to from out in the community, say from like somebody's primary care provider, like their GP. Yeah, we can only receive referrals from within our clinic area. So I think that's the last slide. We'll go to the end there. Yeah.
Thank you so much. That was very informative. There's so much to think about there. We do have a few questions from some of the viewers here. One of the questions is, do you often need more than one appointment to receive a diagnosis?
Yeah, sure, I can answer that one. So typically, the appointment is set up so that we can determine on that first appointment. But on the off chance, there are some people, and I'm sure Maia would agree, that we may have to send for like further testing, which is another aspect of our clinic, like neuropsychological testing. But I would say for the most part, we are giving you a diagnosis on that day. We may need some more information, so it may be, we may need further information to sort of give you that diagnosis. Maia, would you like to speak to that?
Yeah, I think to echo what Janet was saying, that it can kind of happen in a few different capacities. So sometimes more information is needed before a diagnosis can be given. Other times it might be evident from that assessment and a diagnosis can be given. And then with every diagnosis comes recommendations about next steps. And so that's where the collaboration with our allied health partners is often quite relevant, because sometimes we might have an outreach nurse check in a few months' time to see if there has been, for example, let's say a response to a medication introduction or adjustment, or perhaps maybe the occupational therapist will have some suggestions around ways to make the home a bit more functional and safe, and there might be ongoing communication in that capacity. So I think the answer could be both yes and no. So it would be a bit context dependent.
Absolutely. Each case is so unique in these situations. Another question we have from the audience is, what is the difference between urgent and semi-urgent when training people to be seen?
That's a great question, and I'm happy to speak to that because I have spent a lot of time triaging over the past few years. During the first wave of COVID, I did triaging exclusively for our division for about 8 months. So urgent concerns would usually include a component of a safety concern. So often there's a concern about an abrupt change, potentially some changes in behavior. And also sometimes there's a question maybe about delirium, which is a sudden change in thinking, usually related to an underlying medical problem or maybe a medication that needs to get sorted out quite quickly. And there's probably going to be nuance to each of those as well. Maybe we review it and the request is for urgent, but based on the information, it might actually be more appropriate for somebody to be seen at the emergency department. There's also sometimes overlap, particularly for the concerning behavior changes with geriatric psychiatry. So again, if there are very strong psychotic features, meaning a lot of hallucinations or paranoid ideas, that might be somebody who would be better seen by geriatric psychiatry. But typically that would be somebody, the urgent referrals, there would really need to be kind of a crisis at hand that we would be hoping to ideally avoid the trip to the emergency department by intervening as soon as possible. For folks with a semi-urgent concern, and just to add on, the semi-urgent is actually a cancellation list as well. So they would be people who we would aim to see within 3 months, but they would also be offered any appointments that came up through cancellation. So that is partly how we see them so quickly. Those would usually be people where there's a safety concern, but it's not as imminent. So that can also manifest in a few different ways. Maybe there's been weight loss and they're not eating as well. Maybe there's a driving concern that needs to be addressed sooner rather than in 6 months' time. I'm trying to think of some other scenarios. Maybe they've started to have more falls and need to be seen a bit sooner. But the idea, again, is to try to intervene before a health crisis really declares itself.
And I think, Maya, too, I mean, we also have a system in place where when a referral does come in and there's not enough information to make that decision, Dr. Von Maltzhan or whoever's on triage at the time can send it to one of the nurses. I'm one of the few. And we do phone calls to actually the patient's family member who's listed and sort of get an idea of, okay, what is going on? And can you tell us, give us more information as to what's going on and whether we should see them, sooner than later. And that way we have an idea on how to triage the patient.
Absolutely. Thank you so much for tackling that question. It sounds like there's a lot of fluctuating in all of that.
We're busy.
It's more complicated than it seems.
We're very busy too.
Yeah, that's right.
Definitely. It's never kind of one straight line.
More. Yeah, and I'll add one more thing about triage too, Shelby, just because I think this is important to help empower people. Sometimes we might receive a referral and the information at that time sounds like somebody would be seen on a routine basis, but health changes. And if there are changes in the interim where the concern for an assessment or the need for an assessment becomes more pressing, what we typically recommend is people check in with their primary care providers and ask the primary care provider to send us an updated note. And then we would reassess the triage. And we're certainly able to change it if there is new information suggesting that maybe continuing to wait on a routine basis is no longer the best plan.
All right. Thank you so much for that tip. I know that's probably going to help a lot of people for sure. Another question that we have, can your pharmacists do med reviews?
Yes, that is a very helpful service that they collaborate with us on. Can be really helpful in a number of capacities, specifically if we want to taper or change a medication. They can also look at drug-drug interactions. They're a really valuable member of our team.
Absolutely, yeah. Pharmacists are wonderful. We have from the audience, do any of these services apply to residents outside of the Annapolis Valley region, or is it specific to HRM?
Yeah, so our team is specific to Central Zone, actually. And I'm just trying to think of the boundaries of Central Zone. So very roughly speaking, that would extend to Windsor.
Windsor. Yeah.
Going down the shore, it would go down to, I believe, Hubbard's. I always have to look up Chester. I can't remember which side of the line Chester falls on, but I certainly know Hubbard's would be within Central Zone. And then I believe up to Sheet Harbor as well would fall within Central Zone. The Annapolis Valley falls within Western Zone, which is a big part of the province as well. So that's, again, roughly speaking, South Shore and Valley region. We do have a colleague who's a former graduate of our program, Dr. Maggie Lovett, who is based in Western Zone, predominantly in Lunenburg, but so Dr. Lovett works with a team in Lunenburg to provide services to that area and surrounding. She also goes once a month to Middleton to do a clinic at Soldiers Memorial Hospital. And I do see on the Nova Scotia Health website that they are actively recruiting a full-time geriatrician to the Annapolis Valley region. It looks like they would be co-located at the Annapolis Valley Community Health Center, as well as Soldiers Memorial Hospital. There is a multidisciplinary allied health team, I believe, again, based out of Soldiers Memorial, called Seniors Links, that provides support for residents in the Valley region. So there are some some parallels, but they would be a different team. And the benefit for having a local team there is that they do know the resources a little bit better than I would here, our team would know here in the city.
Absolutely, yeah. And there's so many different factors impacting certain populations for sure.
Yeah.
So thank you for providing that information and telling us about things we can be waiting for at different positions coming up.
Yeah.
That's great. Another question we have, if someone gets a dementia diagnosis, how long are they followed by the clinic?
Well, I think it's dependent on the geriatrician that's seeing them. I don't know, Dr. Von Maltzhan, if you want to speak to that, but it's very patient specific, and I think it's also physician specific. Yeah.
Yes, and I think, you know, in full transparency, I think there's been a bit of an evolution over the past 4 years as well. There has been an escalating need for services to support older adults living in the community, to support people living with dementia in the community. And so we have had to adjust our model to a bit more of a consultant model. This is from the physician perspective. And so we often collaborate with primary care in providing diagnoses and recommendations, and then collaborating with our team to introduce plans and recommendations. But I would say the vast majority of our patients are not followed longitudinally. And sometimes what can happen as well is there might be a period of, say, 4 or 5 years that a person is living with dementia, and there isn't really a need for a routine check-in with geriatric medicine. But maybe down the road, a new need arises. And again, at that point, we would just ask the primary care provider to send a note or a referral. And that's another way that we will engage with patients. So we certainly welcome them back if the need arises.
Absolutely. Thank you for that. And then we have a little trickier one, maybe. How do you deal with a loved one who is not wanting to see any doctors but needs an assessment? And to go with that, how do you go about dealing with anger, mood, treatments of caregivers after a visit?
Mm-hmm.
Kind of a two-part one, sorry.
Like a two-part one.
It's certainly challenging. You know, the person who has dementia or who we are thinking and coming in for a diagnosis may not recognize that there's anything going on, you know.
Limited insight.
Limited insight and not really sure what is going on. And so a lot of times, you know, we hear from the patient, well, the wife is making me come to this today, you know. And so you know, I mean, but again, our sole purpose here, we are here to support the patient and support the family member. It's definitely challenging. We've had some, you know, patients show up and they don't want to be assessed, right? And their family member brought them to the clinic. So we've encountered that issue. But I think for the most part, people seem to be receptive. You know, their family doctor has already talked to them about coming to the clinic. And again, our approach is, you know, typically, I mean, I can vouch for all of the nurses here. You know, we are gentle, we are kind and compassionate, and we want to help, and we want, you know, to help you figure out what's going on.
I would say too that if a referral comes in and the patient doesn't show up, sometimes we can identify that maybe it's because they really don't want to have the assessment. We might call them and be able to offer them a home visit assessment with one of our expert nurse practitioners. So they work specifically in the community and they can see people who would rather be seen at home. Would you agree with that, Dr. Von Maltzhan? I think sometimes we can identify that and go about it that way.
Yes, I would agree. I agree with both statements there. So I would actually say the vast majority of the patients who I recall not wanting to be seen, through the skill and talent of the nurses, they do in fact engage in the assessment. And there are certainly occasions where people might not attend the appointment for a number of different reasons, but we do have some strategies, and the outreach is one in which sometimes we can meet people in their environment where they're a bit more comfortable and open to being assessed. I can speak to the second part of the question as well, because it's true, these are sometimes very challenging conversations, emotionally charged conversations, and sometimes support persons are experiencing a lot of their own strong emotions. And this is where I think community resources like the Alzheimer's Society can be very valuable. And we do attempt to connect people with the Alzheimer's Society, particularly support persons or caregivers, because there are a number of different resources which representatives from the Alzheimer's Society can outline and can listen to the concerns of the support person. Sometimes there might be instances as well where the concerns of the caregiver really stand out, and not just concerns, but I think more specifically the emotions. And in that case, we have sometimes involved our psychologist. For the caregiver, sometimes social work can also be quite valuable in this capacity. So this is where the multidisciplinary team, once again, is really helpful, as well as the community supports, because we recognize that the health of an individual living with dementia is often intimately connected to the health of the person who's providing support for them. So it is really important that we ensure that caregivers also have good resources for supporting their own mental health.
Absolutely, you're so right there, completely. It's good to know that some of these things are being thought about, and it's a difficult situation at any given time. One of the questions that we've got a few times actually is, what if you don't have a GP?
This is a real dilemma presently in our province, and I think across many parts of the country. We do certainly receive referrals through Virtual Care Nova Scotia, so I think that is probably the best route to go. Of course, the virtual care clinician might not be able to provide the full complement of assessment that a in-office visit could provide, but they certainly can still provide referrals. Sometimes people have gone to walk-in clinics as well. Not ideal, but that is one way to have that connection made.
Perfect. Thank you so much for answering that. And we'll do maybe one more. Can family members call you directly to talk about a change or issue of their person?
I think that depends on if the patient's been like initially.
If they had their assessment, it often becomes very challenging for us, because we see so many people in the run of a week and a month, and oftentimes, when you're talking to the family, that connection is sort of, we've also, we have to move on to the next person, and in clinic. I know the outreach nurses, like they are doing more of the follow-ups. It becomes very challenging for the clinic nurse, and it is, that's one of our downfalls, because that continuity is kind of lost after the appointment. But we do involve another nurse if there is, and the outreach nurse specifically, to do that follow-up and answer those questions. But a lot of times too is, we sort of emphasize in our clinic appointment that, the Alzheimer's Association people are there. Like, they're the people to talk to if you have questions after our appointment. It's a lot to digest. And you're hearing, a diagnosis possibly, and you leave there with lots of questions on your mind. And so that's why we sort of set up the first link referral also, which, is helpful in that process, I think, anyway.
Yeah, I might add there, so certainly if there are sudden changes in behavior, thinking, again, connecting with primary care would be really important, as they might need to do blood work or investigations to make sure there hasn't been an acute illness that's come about. For those individuals who are partnered or receiving care through Continuing Care Nova Scotia, there's also a really wonderful resource called a behavior support team. And they're a dedicated team that can be consulted through continuing care to help individuals living with behavioral and psychological symptoms of dementia. So that's another strategy. Typically, you know, especially if it's been several years since the person was assessed by geriatric medicine, it would not be ideal for a family member to reach out with concerns. That would definitely be the route where they need to touch base with primary care first. But if it's been a recent visit and let's say it's in response to a medication change, I think it would be very normal to have the office updated that something's not going well, and the team would respond accordingly. Shelby, I got a few direct messages as well that I could quickly answer.
Absolutely.
If time allows. So one was, how often do we receive a referral that results in a diagnosis that there is no dementia? So every now and then that does happen. There are certainly changes in our thinking as we get older, and not all changes are related to dementia. Sometimes we in fact discover that the thinking changes might be more related to depression or anxiety. I'd struggle to put a frequency on that, but it is certainly a potential outcome. And then there was another question about how the memory tests are scored and what's the significance of the score. So the scores are tallied, and there are cutoffs for what would be considered quote unquote normal. And then below that would be considered either a mild impairment, a moderate degree of difficulty on the test, or a severe difficulty. And there's a lot of contextual aspects that go into interpretation of the score, somebody's past education, somebody's first language, whether they have any sensory problems, so hearing or vision concerns. That would all be interpreted as well. And it's kind of a global impression of all of the different aspects of the assessment.
These were great questions. Yeah, thank you, everyone. Yeah, it's a topic with many questions to come along with it for sure. So we appreciate all of your questions. And thank you for answering as well.
Our pleasure. Thank you for hosting this and providing the opportunity.
Yeah, thanks so much.
As we begin, oh, sorry.
That's okay. Thanks so much for inviting us.
Absolutely, yes. As we begin to wrap up, you may see a poll kind of pop up on your screen. So please take a minute to respond to these. It just helps us learn for next presentations to come. And thank you, Kate, Janet, and Dr. Von Maltzhan for sharing. And I would also like to thank everyone for tuning in today. So please send any comments or suggestions for topics in the future to our office, which is the number that you can see on your screen below. And additionally, like we talked about before, the Alzheimer's Society is always here to chat. So you can also use the number on your screen, which is our dementia helpline. And we have staff that will call you back if you have any questions or would just like to chat after this session today. This session was recorded and will be hosted on our YouTube channel for you to share or watch later if you wish. And thank you all and enjoy the rest of your day.